introduce the webinar, I did want to just let everyone on the line know that we are planning to show a video toward the end of the webinar. It's part of our presenter's presentation. And when we get to that point, most of you are dialed in via the phone, so you'll need to mute your phone, and more importantly, because we'll be muting the lines at that point, we need to have you turn the volume of your computer up so that you can actually hear the audio. You won't be able to hear it through your phone. So we'll make a reminder of that when we get to that point, but I just wanted to let you know that now. Okay, so let me welcome everyone to our 16th webinar, and I do appreciate folks making themselves available today, as our speaker was unable to be available yesterday. So I do appreciate everyone's making this option work. So today we'll start with just the regular housekeeping. We'll spend just a minute or two talking about our upcoming webinar schedule that we'll be using as we close out this learning network into the first part of the year. And then we're going to have our feature presentation today, which is really all about critical thinking skills for fall injury prevention. And this presentation was originally we planned to have Kate Walsh, who developed the presentation, deliver it, but today instead we have Dr. Norma McNair, who will be presenting, a colleague of Kate's, because she's unavailable. So we look forward to hearing Dr. McNair share the work that's going on at their facility, and then we'll wrap up. So just a few housekeeping reminders. Again, you can always use the hand feature to let us know if you have a question or a comment, and you can also use the chat panel. We do ask that you keep your background noise to a minimum so that we don't have a lot of background interference. You can mute your phones, or you can also mute yourself through the WebEx. And again, just as a reminder, when we get to the video, you will need to turn the computer volume up. We don't want you to do that now, but when we get to the video, you will want to do that. Okay. So just a little bit about our upcoming webinar schedule. So next month in December, we will have another guest speaker. Her name is Susan Mascioli. She's from Christiana Care Health System, and she'll be doing a presentation on a Lean Six Sigma process that they have instituted at their facility. And then, as you all are aware probably by now, beginning in January and going through March, we are planning to sort of turn the mics back over to the hospitals and have the hospitals provide some updates for the monthly webinar. And you'll see here we have a couple of things that we were hoping that each of the hospitals could present on. Those things that you feel you're doing now or doing better now since you started this program to improve care for patients. Any plans that you have for your fall prevention teams after the conclusion of your participation in this program. And we know that your efforts will continue even though the program has ended. And we just would like to, have an update on what your current plans are. And then any barriers or challenges that you are currently dealing with or that you anticipate as you move forward. So we're looking forward to those presentations. And I know that your QI specialists have been working with you to identify the times with which you guys will be doing your presentation. So again, we look forward to those presentations. So at this point, let me introduce our presenter today. We have Dr. Norma McNair. She's a clinical nurse specialist at Ronald Reagan UCLA Medical Center. And she works with Kate Walsh. As I said, she's a colleague, and unfortunately, Kate couldn't be with us today. And so she's going to be talking about the work that they've done there around critical thinking skills. for fall prevention. So I'm going to pass this over to you, Dr. McNair.
Thank you. Good afternoon, everybody. Thank you for joining us today for this presentation. I'm privileged to be able to provide this presentation for Kate, and I look forward to hearing what you have as far as comments and questions. So to start with, let's just talk a little bit about the types of falls that ordinarily happen in the acute care setting, hospital setting. First of all, the accidental fall. This is the fall where the patient slips in water on the floor or urine, or they get up to get their call light to call the nurse, or they trip over something. The second type of fall is the anticipated physiological fall. And this is really for the nurse to really be thinking about what in the patient history do you know, and how to apply that to falls. So, for example, is the patient on statins, has osteoporosis, has liver failure, has certain kinds of disease states, certain types of medications, diuretics particularly, or stool softeners or laxatives that may increase the risk for the patient to fall simply because of their underlying condition. The unanticipated physiologic fall is the patient who is up and has a stroke or an MI or a seizure, not something expected, and the patient ends up on the floor. And then the last one, the planned fall, is generally when the patient decides that they need some attention. So they may put themselves on the floor, not really fall. And then there are the developmental related falls related to pediatrics, but we're focusing on adults today. So the only two that can really have outcomes changed for are the accidental and the anticipated physiologic fall. So here are the objectives of the talk today. We want you to be able to incorporate critical thinking into staff education regarding falls and fall prevention, to implement a post-fall huddle process in your own institution, and utilize teach-back methodology and patient-family education about fall injury risk and prevention. So our facility uses the Morse fall risk assessment tool. It is probably one of the best that up until now that has been validated in the acute care setting, but it's still not perfect. It is a rolling benchmark. So what that means is as things change with the patient, the nurse should be reassessing and documenting a new fall scale. I can probably guess at most places that doesn't happen. And the other thing about the Morse fall risk tool is it targets only the anticipated physiologic falls. So we have to really think about what are we doing for our accidental falls, and also keeping in mind that all of our patients are at risk for fall. Anybody can fall, and especially when the patient's in the hospital and a lot of things are being done to them, anything could lead them to fall. So I'm from California, so I'm going to talk about what our Nurse Practice Act says, and it delineates the scope of registered nursing practice and defines the nursing profession's accountability to the public. And it states our most basic independent functions are to ensure the safety, comfort, personal hygiene, and protection of patients. So what else can we do to make sure that our patients are safe from falling? So one of the things that we implemented, and I think a lot of people are using this now, are the 5 Ps, where we think about pain, personal needs, positioning of the patient, placement of their personal items, and then preventing falls and injury when we round. So what we're trying to do here at UCLA is to really incorporate critical thinking into the 5 Ps. So the ANA Scope and Standards of Practice state that registered nurses employ critical thinking to integrate objective data with knowledge gained from an assessment of the subjective experiences of healthcare consumers, and that registered nurses use critical thinking to apply the best available evidence and research data to diagnosis and treatment. So that's what we want to kind of focus on today. So critical thinking skills include reasoning, evaluating, problem solving, decision making, and analyzing. And this is in a circular, it's an ongoing circular process. So the issues about tools and checklists and assessment tools, they don't really take into account the patient's individuality, what is specific about that patient. And critical thinking really is the antidote to task-focused care. We really don't want people going just willy-nilly rounding and not really thinking about what they're rounding on or why. So I'm going to give you a little story about critical thinking in everyday life, and then we'll translate that into a patient scenario. So you are leaving your mother's home with your 2-year-old son, Ricky. Ricky runs in the front yard while you talk to your mother. Down the street, a teenage boy is riding a skateboard and he's coming toward you. You must make sure Ricky doesn't collide with him as he passes the house. From the opposite direction comes a woman walking her big dog on a leash. Ricky loves dogs and usually runs directly toward them. You'd better take his hand until you learn if the dog is friendly. The skateboarder and dog are gone. Your mother is still talking. Ricky has picked something up from the ground and he is about to put it into his mouth. You rush over and take it from him. The 5-year-old who lives next door just came over to say hello. He pushes Ricky to the ground. Did his mother see that? You're ready to attack. So you're constantly assessing, diagnosing, identifying outcomes, planning, implementing, and evaluating in this very everyday life situation. So how does that translate into clinical practice? So in the inpatient setting, registered nurses are legally and ethically accountable to do the same critical thinking for their patients. Nurses must make it their habit to intentionally put together everything they know about a patient in the moment to come up with the best strategies for right now. So here we're gonna walk through a patient scenario, and you can just jot some notes to yourself as we walk through this, and then I will give you the answers. So at 7:15 in the morning, a shift report reveals that the patient is a high fall risk, and the RN reminds the patient to call for help using the call light when he wants to get out of bed. So what are some critical thinking things that the nurse should be thinking about as she gets this information from the patient or from the nurse? So some of the things that she should be thinking about is, does the patient know how to use the call light? And how well does he remember instructions? Does he know he's a fall risk and what that means? Does he realize how unsteady he is? And did the registered nurse discuss the fall risk with the care team for the other people that would be coming into the room to visit with this patient? So the registered nurse administers a bunch of medications: hydrochlorothiazide, Colace, benazepril, Prozac, amlodipine, Vicodin, and Protonix. So again, what are these medications going to do that are going to increase the patient's risk for falls? So hopefully the registered nurse knows that hydrochlorothiazide will induce urination, that Vicodin may make him more unsteady, that antihypertensive may make him dizzy, and other medications may make him need to go to the bathroom. have a bowel movement or just feel the need to go. So is the care team aware of all of these things so that they can proactively help this patient? So at 10 o'clock, the registered nurse and the nurse's aide give a bath. A half an hour later, the patient has to urinate. He tries to use the urinal sitting in bed, and he cannot. So he sits at the edge of the bed and cannot void. So he stands at the bedside holding onto the rail and feels dizzy. He almost falls, but he succeeds in using the urinal. The aide enters the room 20 minutes later and empties the urinal. So here are some things that might be considered. The big thing, the aide doesn't ask the patient how they managed to urinate, and not really taking into consideration many things, but this is probably the biggest thing. How did this man use the urinal? So the patient goes off the floor at 11:30, and the nurse is charting, assessing the vital signs, the pain, the INO, and the plan of care. So the RN isn't really thinking about how the patient urinated or how he felt when or if he got up, and has the care team really discuss the patient safety issues around this patient. So at 1 o'clock, the patient transfers to the chair with maximum assistance of the aide and agrees to sit for 30 minutes and have lunch. The call light and the urinal are within reach. 10 minutes later, the patient needs to urinate. Remembering he almost fell, he calls for help. The secretary finds both the aide and the RN busy, and the secretary does not follow up. So 10 minutes later, the patient cannot wait, carefully arises from the chair and urinates. The RN checks on the patient and empties the urinal. So again, the nurse didn't ask how the patient urinated. And so is the team talking with one another about this particular situation with this patient? So at 3 o'clock, the RN performs rounds on the patient. He requests and receives Vicodin. 2 visitors enter with lunch and the patient's favorite large coffee. So does the RN note that the patient may be more unsteady as a side effect of the medication and that he'll need to urinate more often after coffee? And is this information, again, shared with the care team? So the nurse assists the patient back to bed and sees how unsteady he is and reminds him not to try and get out of bed alone. 20 minutes later, the patient feels the need to have a bowel movement and to urinate. He is shy about having someone with him and remembers he was able to get up by himself, so he decides to go to the bathroom alone. And guess what? He falls. So again, these questions come up ongoing through this patient scenario. Is the care team aware of the RN's latest assessment? Does the patient know how to use the call light? Will he follow instructions? Does he remember the information that's told to him? Is there anything that's inhibiting him from remembering what the nurse has said? And this is a great opportunity to kind of just interject the whole idea of teach back with the patient as you're discussing their fall risk, having them teach you back what they learned and what they're going to tell their family. So the nurse is completing the documentation and feeling fortunate that she's had a smooth shift. The aide rushes in to say their patient has just fallen and she must come to the room immediately. After putting the patient back to bed, the nurse assesses the patient, calls the physician, and arranges for the head CT. So the RN is now staying in the room to monitor the patient. She gives the shift report, and now she has to fill out an event report and document the fall. So through that scenario, the idea is really to hope that the nurse is constantly thinking about the issues that may lead to a patient fall. Now, one of the things that we've implemented here, and I think other organizations have done as well, and we actually borrowed this from a hospital and kind of adapted it to our own use, is a post-fall huddle. And this is really a debriefing after the event. Hopefully, it's conducted within the first 15 minutes after an event, if at all possible. Sometimes that's not possible, but the idea is to get it finished as quickly after the event while everything's still fresh in everybody's mind. And it uses an experiential learning method. So generally the charge nurse or the nurse involved or the clinical specialist or anybody sort of in that role can get everybody together, the patient, the nurses involved, the nurse assistants, the family, and talk about the circumstances leading to the fall, and then talking about interventions that may have prevented the event from occurring. We have found this to be really helpful. It really heightens the awareness of the nurse on what needs to be done and helps to improve the outcomes that we have after learning about the potential issues for patients who fall. So just want to talk about, is this your fall bundle? Armbands, falling star signs, bed and chair alarms. Armbands are wonderful, especially when the patient goes off the unit. There's a very clear, readily identified information that anybody can see, and it helps to identify those patients, especially when they might be going to someplace like radiology where they're having to move around a little bit. But one of the things about having falling stars and things like that is if they're put on every patient, if every patient's considered a fall risk, which in the hospital they probably are, how does anybody not become immune to those signs? We don't even use them in our ICUs because every single patient would be a fall risk and have a falling star outside their door, and it would just become unuseful. We hope that this helps to identify patients who potentially could have an injury and heighten awareness by the care teams as they're making rounds. Bed alarms don't necessarily prevent the patient from falling, but they are an early warning system for nurses to hopefully get into the room before the patient gets out of the bed and provide timely rescue. We have ours hooked into our call bell system so that there's a couple of different kinds of alarms that go off when the bed alarm goes off. And we actually use pads in the bed because those bed alarms are much louder and can be heard better through doors that may not be all the way open. And the alarms that are actually in the bed are not necessarily as loud or as helpful. So I mentioned Teach Back a little bit ago, but again, just want to circle back to that and talk about what is Teach Back. I think most of you know that it is in a situation where the patient or the family explains in their own words what they need to do or know. This way, we can be assured as providers that we've explained the information clearly and that it's not a quiz or a test for the family or the patient. It's really to assure that they understand. And it really helps the nurse to check the understanding and, if needed, to re-explain it more clearly. It is a research-based health literacy intervention that improves patient and provider communication and patient health outcomes. And the way we use it here, we just say to the patient, okay, now we just talked about your fall risk. What are you going to tell your family when they come about what we just talked about? So that's a good way to kind of get a good assessment. But there are some things that do have to be taken into consideration. One is the patient or the family member English proficient? If English is a second language, they may not completely understand what you have said. It does help patients and families understand their risk a little bit more. For example, you're taking pain medications or a stool softener, they may make you more at risk for falling. But patients who do not speak English or the same language as the registered nurse or the provider will need to have an interpreter. So that's where interpreter services are really helpful in helping to provide that education. So here are some advantages, some benefits of TeachBack. One is that it really puts the onus on the healthcare provider to be sure that they are clear in their explanation and that the patient and family understand. It helps nurses to identify knowledge gaps and obstacles to a safe discharge. It allows time to find resources that will rectify the gaps and obstacles to a safe discharge. So whether that means materials in the patient's language or an interpreter. And it allows time for patients and families to demonstrate or practice a skill and new knowledge before they go home, and hopefully lead to less risk of readmission. So how does this work with falls? So we tailor our fall instructions to the patient, discuss the fall risks with the patient and the family, and explain why the patient is at risk of falling. So for example, Mr. Smith, you're taking a diuretic that it makes you make more urine and makes you have to go to the bathroom more often. This is because you're older and maybe a little bit weak from being in the hospital. We don't want you to get up on your own and fall. So then again, like I said just a moment ago, in using TeachBack to make sure that the care provider follows up by saying, just so I know I did a good job discussing your fall risk with you, can you tell me what we just discussed about fall prevention as if you were teaching a family member or friend? There's lots of variations on that, but I think it works really well when you say something to the lines of, what are you going to tell your family when they come in about what we just talked about? So there's much evidence for using TeachBack in many, many ways and many different situations, medication use, and so we, and other patient education information. And so we use this to support the work of TeachBack that we're doing here at UCLA. So the thing that is really important is that learning must lead to a behavior change. So Dale's cone of experience talks about at the top of the cone, if people just read something, they may remember 10% of what they read, 20% of what they hear, 30% of what they see, 50% of what they hear and see, 70% of what they say and write, and 90% of what they do. So what I'm hoping here too is that by the time we're finished, that you'll have remembered a good deal of what we've talked about, and we'll be able to use it in your own institution. All right, so one of the things that we use here at UCLA are simulation scenarios to get the nurse to think about how to do fall prevention. And so simulation is used to improve bedside nurses' early recognition of the most frequently overlooked patterns. So we want to target the most commonly overlooked clinical patterns, teach staff to recognize those patterns early and intervene appropriately, and provide direct, concrete experiences in application, and offer opportunity for immediate feedback from their peers. So what we're going to do is show a couple of videos. I think we might have time to do both of them. So the first one is a simulation scenario for nurses, and then the second one is for staff that are not nurses. I think that this will help you understand a little bit more about what I'm trying to communicate. There are places in the videos where it says to pause, to talk about critical thinking, but we're not going to do that. We're just going to go right through. So if we could start the first video, and then remember, everybody, mute your, turn up your volume on your computers and mute your phones. Okay, so this is the first one.
The patient you're about to meet was an active, relatively healthy grandmother a few weeks ago. Today, it's a different story. She went to the emergency room disoriented, suffering from what appears to be UTI and symptoms of urosepsis. She also has a history of osteoporosis. Is she a high fall risk? Well, let's see how our nurses in the med-surg unit deal with this scenario.
Okay, Ms. Hammond, my name is Stella. I'm going to be your nurse today, and this is Katie. She's going to be your nursing assistant, and we're going to be taking care of you today.
Hi, Ms. Hammond. I'm going to write our names on the board so you know who's helping you.
Take your temperature.
Ooh, I see your hearing aid fell out. I'm going to put him in the case right by your bed.
Let's make you more comfortable and take these glasses off as well.
I'm going to take your blood pressure. Ooh, your cane. Let me put this in a safe place. I'm going to put it in the closet.
Okay, Ms. Hammond, this is going to be your call light, okay? What you're going to do is push the red button. You're not to get out of bed by yourself, and we'll be in to check up on you. Do you have any questions? Do you need anything right now? Okay, well, we'll be in a little bit to check in on you, okay?
All right, we'll see you in a sec, Mrs. Hammond.
Let's take a look at that temperature.
What do you think is happening here? And what do you think could happen next? Please pause this video and critically think about this scenario, and we'll see what happens to Mrs. Hammond when you're ready. The nurse that just rounded thought she was doing the sleeping patient a favor by closing the curtains, but the result was that the already disoriented patient got even more anxious. What would you have done differently? Think critically about what these nurses should have done, and we'll show it to you when you're ready.
Okay, Mrs. Hammond. My name is Stella. I'm going to be your nurse today, and this is Katie.
I'm the nursing assistant with you today. I'm going to put our names on the board for you.
And both of us will be taking care of you today, okay? Let me take those glasses off so that you feel more comfortable.
Ooh, Mrs. Hammond, I see your hearing aid came out. I'm going to put them in the case.
Oh, actually, Katie, I think we should put them back because, you know, she's not going to be able to hear or see if she doesn't have these on. Let's leave them on just for now.
I think I should get a hard of hearing form over her bed so the rest of the staff knows this is an issue.
That's a great idea. And that form is just to let all the staff know that when they come into this room to talk to you directly. Let's get some vitals on you.
Okay, let's get this on your finger.
Oh, actually, you know what? Before we even do this, Do you want to use the restroom? No. I think we should try. Come on, we'll help you. We'll help you. There you go.
There you go, Mrs. Hammond.
Okay, Mrs. Hammond, this is your call light right here. This red button right here, please push it if you need anything, but especially if you want to get out of bed. Let's try that to see if you can do it. Let's see if the call light works. Very good. Right under you is a bed alarm. Now it will sound every time you shift, but don't worry, it's just to alert us that you may be trying to get out of bed. I will just come in right away and turn it off.
I'm going to go ahead and put this cane in a safe place.
No, not my cane. I need my cane.
Mrs. Hammond, I promise you it's going to be in a very safe place, but it's very important that you use this call light and call us when you want to get out of bed.
And Mrs. Hammond, I'm putting the commode right by your bed, just in case in the future, if we need to use it, it'll be easy for us to get you in the commode, but you definitely have to use the call bell and let us know that we need to assist you.
Mrs. Hammond, do you need anything else? Okay, once again, my name is Stella. I'm your nurse.
Yeah, and I'm Katie, and I'm your nursing assistant all day long.
And we'll be back in around 30 minutes to check in on you, okay?
That turned out much better. Here are some key points to take away from this scenario. Since osteoporosis is a condition that can put a patient at risk for a bad injury if the patient falls, think about what you can put in place to prevent an injury if a patient does fall. Can you think of other conditions that could produce a bad injury if a patient falls? Some examples are a patient on Coumadin, a patient who has a high INR, a patient who has low platelets. No background history well for all your patients. Think about how the patient is affected when you take away his or her ability to see or hear. Think about important handoff information that can help prevent a fall or injury from a fall. Always have your patient perform a return demonstration if the patient is confused, has sensory issues, or does not speak English as a first language. Thank you for watching, and remember, there are always things we can do to help prevent falls or fall injuries.
So that was a video that we use for the nurses who work on our med-surg areas. We also have videos for the intensive care unit, for neurologic patients, for liver patients, etc. But we also have this video that I want to show you that is for staff that are not nurses. So for your environmental services staff, your food delivery people, physicians, other individuals who work in the organization who may need information about falls. So we'll go ahead and show this one right now.
So you're not a nurse. What does this topic have anything to do with you and your role in a hospital? Minimizing hospital fall risk and injury is now everyone's responsibility. Nationwide, statistics show as many as 15% of inpatients experience at least one fall during their hospital stay. About 1 in 3 of those falls cause injuries, including bruises, lacerations, fractures, intracranial bleeding, and even death. This video is designed to educate you about fall risk and help you understand what you can do to help prevent falls, whether you're a physician, food ambassador, physical therapist, respiratory therapist, spiritual worker, cleaning crew worker, phlebotomist, hospital administrator, or just about anyone else working in an inpatient environment. It's important to understand that all patients are at risk of falling in a hospital, no matter what their health or condition. In this video, we will mainly be focusing on patients categorized as high fall risk, but keep in mind that many of the topics covered here are important to all patients. Do you know what this sign means? The national color for high fall risk is yellow. Although this is the recommended color, it's not mandated. Please check with your nursing department to see which color, sign, or wristband is used to indicate a high fall risk patient. So now that you've noticed the high fall risk indicator, what does this mean for you? First, if you notice that the door is closed or the curtains are drawn, please check with the registered nurse to see if it should be opened. Having the door and curtains open allows the nursing staff to maintain a clear line of sight to the patient so that they can observe any potentially risky activities. But the decision to keep the door open or closed is up to the nurse. Second, if you notice that the high fall risk patient is getting up without assistance, ask him or her to please sit down and press the call light. The patient should have already been instructed to use the call light, but many patients don't because they either forget, want to be independent, or feel what they need is so minor they don't want to bother anyone about it. But there is no exception to this rule. High fall risk patients must be assisted 100% of the time when they get up. And finally, if you find a high fall risk patient alone on a commode or in the bathroom, notify nursing staff immediately. This situation can be very dangerous for the patient. Here are some general things we should be on the lookout for at all times with every patient. If you notice any spills on the floor, either inside or outside the patient's room, notify unit staff immediately. If you move anything while treating or working with the patient, make sure the nurse is aware so he or she can troubleshoot any fall safety issues before you leave the room. Even if the patient is with family members, don't assume that the family has been educated in fall awareness, or even if educated, that the family understands subtle, important measures to ensure patient safety. Now, here are some key points that apply to specific staff members. Physicians, please include fall risk as a category when rounding or performing interdisciplinary rounds. Look to see if any meds that are considered high fall risk meds, like diuretics, laxatives, or sedatives, can be eliminated or changed to better scheduled times so that the combination of drowsiness and frequent urination can be avoided during nighttime hours. Always notify an RN when you remove restraints or if you change the patient's positioning. Pharmacists, when teaching patients about drugs, please make sure that the patient is clear about which ones can increase the likelihood of a fall. Food ambassadors, food trays should be placed within reach of patients. If the patient has been identified as a high fall risk and is sleeping when you come with the food, please don't leave it out of reach or at the door. Cleaning crews, as you clean your areas, please pay special attention to all open rooms as you go by. If you notice a spill or anything else that could be unsafe, please clean immediately or notify a nurse. Physical therapists, please make sure the patients you are seeing know their capabilities. For instance, patients may feel that since they just walked with you using a walker, they can now perform this task on their own. Please clarify whether this is the case before finishing the session. Central supply. Please check routinely to see if a piece of equipment is in good condition before you send it up to a unit. If equipment like bedside commodes are kept in the unit, please have a person check them at least once a year to make sure they're in good working order and condition. We hope you're able to take away key points from this video that will help you prevent falls. Thank you very much for watching, and remember, keeping patients safe is all of our jobs.
So you will have access to these videos by using these links, and then use the password FALL. So for those of you who may just be beginning this journey of fall prevention or need additional things to help, you want to think about a few things. So first, you want to really make sure that you have a good understanding of the falls and fall with injury data that is on your unit or your department or your hospital. Some floors have higher falls than others. For example, in our hospital, it's our liver transplant floor, our neurosurgery floor, and our bone marrow transplant floors tend to have high number of falls. Review your mini root cause analysis or your Postfall Huddle data. kind of look to see if you can determine from looking at that data what it is that causes falls on your units. Here at UCLA, the majority of our falls are related to toileting, coming to or going to or coming from the bathroom. And kind of try and get a sense of the culture of your floor, how willing and able are they to move forward with this type of intervention, and really understand how this can be enculturated in your area. So really the whole goal of a good fall prevention program is that it just kind of becomes second nature to the nurses while they critically think about each patient. And if you're unit-based, you probably already know your fall risk issues and the priorities for safety on your unit. But these are some things to consider. So if you do have any questions that we might not get to today, you can email me, and I am definitely keeping Kate in the loop on how everything goes. So if you have questions now, I think we can take them.
All right. Thank you, Norma. That was really a great presentation. So I'd like to open it up for our hospitals if they have specific questions. We've learned a little bit about Teachback. I think that was something a little unique for this series. So please feel free to ask any questions. Chime in or raise your hand, one or the other. And remember, you may be on mute, so if you are, you're going to need to unmute yourself. I see Barb Rebold has a question. Go ahead, Barb.
Can't hear you.
Barb, you may need to unmute yourself. Well, while we're waiting for Barb to get unmuted, and feel free, Barb, to chat it in if you're having problems with being with your mute. But I wanted to just find out from Norma, with the Teachback, do you find or have you found that works better with certain groups? Because I know one of the things that we hear often, and you even sort of alluded to, the patients oftentimes don't really understand or think that they're a fall risk. They don't necessarily have to be the oldest or weakest. They may be people who are on various medications that, now make them more vulnerable. And do you find that Teachback works better with one particular population than another, or just out of curiosity?
Well, we've been using Teachback in our organization for medication education for a while, and only fairly recently have started using it with fall risk with our patients. So I can't say specifically because we don't really have any data about it yet, but my guess would be that that as patients really understand why they might be at risk for falls, and they can tell you, I think that makes it better. Obviously, patients who are very confused, have short-term memory issues, patients with head injuries or strokes or things like that may not be able to really provide information back to you. But certainly patients who are otherwise neurologically intact should be able to provide information, the information that you taught them back to you. I think it's really just a matter of assessing the patient and dealing with it individually.
Mm-hmm. Okay. Other questions? Have any of our hospitals who are on tried implementing Teachback with patients? We're not hearing any voices. And Barb, I see your hand is still up, but we can't hear you.
Did we unmute our lines?
Yes, I think the lines are unmuted.
Yes,
Okay.
all lines are unmuted. If anybody has a question and you're not able to verbalize it over the phone, you can use the chat area to submit it.
So while we're waiting for any questions, the other thing about fall and fall injury prevention is really that it is something that takes time to become enculturated. We have been able to sustain our program and keep our numbers down over many, many years of working on this. So,
right.
So Cheryl Harris says that we are starting to incorporate Teach Back for falls in Virginia. Is that correct?
Oh no, at the VA.
At the VA. Okay. Thank you.
All right. Well, so how many videos are part of that collection?
I think there's about 5 or 6. Because we have one that talks about just the 5 Ps and what that means, and then we have several critical thinking scenarios for nurses to really think about. When I show these videos to new graduate nurses in our new grad residency, they're already thinking critically about these things. They certainly can recognize when the nurse did something that they probably shouldn't have done, or maybe wasn't the wisest thing to do.
Right. Do you find that different levels of staff feel a little more intimidated about using these types of skills?
Yes, and I think one of the things that we really are, along with the critical thinking component, is really the purposeful hourly rounding. It's not just going in and poking your head in and asking if the person's all right, but to really do that assessment and get the patient up to the restroom, make sure that their bedside table is nearby, reposition them, give them pain medication, all of those kinds of things, and really think very purposefully about the rounding.
Right. So how would you recommend if one of the hospitals wanted to utilize these videos, incorporating them into staff education? Would you have any recommendations on the best way to approach that?
Well, we do it as part of our annual, we do it as part of new hire orientation, and then we also do it as part of our annual education. So the nurses are assigned a video to look at over the time in which they do their annual education. So that's one way to do it. I think when we first did it, we rolled out kind of a big bang to the units that were involved. We had staff from all the different units who did videos participate in identifying the scenario and what the issues were, what the critical thinking was. So we have many that can be used. But we did, on those units, have them review the videos.
Right.
So there's lots of different ways you can do it depending on what the culture of your organization is.
Right.
And to answer your question about access to the videos, the links are on the slide, but you'll probably have to cut and paste it because it won't come up from the slide. And then the password is fall.
All right. All right. Well, if there aren't any other questions, I think that will conclude our webinar for today. So thank you again, Norma, for your presentation. It was excellent. A lot of great useful information, especially around Teach Back and using those critical thinking skills. So if you are able to, we hope that you will complete the post-webinar evaluation, and we look forward to our next session in December, where we'll be hearing about one hospital's use of Lean Six Sigma. So with that, I will say this webinar is adjourned. So thank you, everyone, and thank you again, Norma.